Hello, friends. For those on the phone, super excited for today's session. My name is Dave Servidinio. I am the Director of Marketing at Provider Trust, and we have an incredible guest with us today that we're really excited to deliver you some awesome content. So I will go ahead and share my screen and kick us off with a couple of introduction slides so we can get going. Today we've got, that's the wrong button. It's present, not share. Today we've got a special session for you guys. So we are continuing our series of executive briefs. Our last one, we had a well-known surgeon, Dr. Marty McCary, join us and go through a lot of COVID, just some of the data that was coming out of Johns Hopkins. Our next one is next week, and we have a VP of Compliance from Ochsner Health System joining us. And today we have an incredible topic for you. So just building a provider network strategy while navigating COVID. And we have a guest, Eric Lyle. Super excited to have Eric join us today, and I will introduce him in a second. A little bit about us, if you don't know who we are, if this is your first session with us, we are Provider Trust. We are a data and technology company. We are based in Nashville, Tennessee. We do things like ongoing monitoring and provider eligibility and workforce eligibility. So in the provider world, we help make sure you have the right folks on the floor delivering care at all point in times, and on the payer side, making sure that every provider in your network is eligible to do so at any given point in time. As part of what we believe a smarter healthcare makes a safer healthcare. And as part of that strategy, what we try to do, very intentionally so, is deliver insights, stories, and best practices to the market that help our friends in healthcare across providers and payers really get a flavor for different points, different strategies to help us all just get a little bit better with the end goal of making healthcare safer for the patient is really what our aim is here. So with that, I would love to introduce our guest today, Eric Lyle. So Eric spent 20 years in the Air Force, 6 years of that as a medical service technician, and 14 years of that as a medical service officer. Following his long career in our military, he joined Humana as an analyst and left Humana as the COO for government business as Humana changed the operation from military to government business. From there, joined the Highmark Blue Cross Blue Shield to really leave the military business and come on to civilian healthcare and understand that side of the business as well. And really, there's a lot of insights that I'm sure he'll get into today, but from his time in Highmark and just trying to eliminate leakage and aligning a payer system with a provider system, I think is really interesting and relevant for a lot of folks on the phone today. From there, joined PA Health and Wellness with his Centene's Pennsylvania plan as their CEO to drive the strategy for PA Health and Wellness. And then from there, left for Optum Care in Texas, and now WellMed, which primarily serves, and Eric can correct me if I'm wrong, but primarily serves the Texas and Florida markets and partners with insurers to do so. So a long career working with 4 of the 10 largest insurers in the country, many of whom are actually on the phone today with us. So we're super excited if you're here and you're from one of these organizations to have potentially an old colleague on the phone. And if you're not, have Eric join and really deliver some insights and best practices from what he's seen in his career. So Eric, first and foremost, welcome. And then secondly, would love to, on behalf of everybody here, thank you for your service to the country and for everything you've done to help move us forward. And then I'll kick it to you here to say, after this career, tell us a little bit about WellMed, about your role as EVP of Development and Provider Strategy, and what that looks like on a day-to-day for you.
Yeah, thanks, Dave. It's a pleasure to be with you today. Thanks for the recognition of the service. It's always an honor to be recognized as a former member of the military. And I know for the folks on the phone, you're looking at me and you're saying, look at that hair. We were talking, Dave and I were talking before this call, and typically my hair does not look like this. I haven't had it cut in 3 months because of the COVID thing. And because my wife is saying that she kind of likes it, so we're just going to kind of leave it there for a little bit. But yeah, at WellMed is a care delivery organization that's a part of Optum Care. And the way Optum Care has established itself is they have care delivery organizations that represent different geographies. WellMed covers the Florida and the Texas markets. And so, as it relates to provider strategy and development and acquisitions, that's kind of the role that I play for Optum Care in the Florida and Texas markets, which means that we're out there setting up clinically integrated networks. We are establishing relationships with providers of all types, and we're in some cases looking to bring folks into our organization through acquisition or through partnerships of some kind.
Awesome. I guess, talk to me a little bit about the experience of going from the military world into the civilian world, and specifically that transition to Highmark. And I know that you talked a little bit about in some of our other conversations about the Allegheny network and trying to connect a provider system and a payer system. And that seems to be, as you jumped into the insurer space, talk a little bit about that transition, the parallels, and some of the things that really stuck out.
Yeah, it's an interesting transition. I was talking to a colleague of mine who was in the military as well as I was. One of the last roles I had in the military was doing something very similar, where we're trying to set up the TRICARE insurance plan and the folks that are participants in the TRICARE insurance plan to have them get their care inside the military healthcare system. And there was no regulation or law that would require them to do that. So we had to provide incentives that would force them or encourage them to go and be a part of the military health system. Similarly, at Highmark, when I moved there to be customer operations and chief customer officer, our intent was to try to align those systems. And so, because you can build products around it to help, encourage folks to participate in participating providers, in which case, your system is the participating provider. So you can build products and hopefully that are lower cost products that would encourage folks to participate and buy into it, or encourage companies to participate and buy into those products. Outside of that, you have to build a strategy around brand for your organization to help people understand that they're not the lower alternative in the market and that they're a prime choice for them to go to. So providing incentives and providing encouragement through brand development were the two things that we really focused on. And over time, I've noticed in the industry that all organizations have started to do this. So Highmark at the time was sort of an innovative organization. People have tried to merge insurance and hospital systems together in the past, and it's always been a struggle. Highmark tried it, and I think they're still moving down that path and trying to follow that journey. Other organizations have started to do that as well, and they're doing it in different ways. The organization that I'm a part of today is doing that. So United Health Group sort of saw the writing on the wall, and they decided that they wanted to participate with physician groups in the market that would help drive patients and membership into their system in a risk model. We can talk a little bit more about what that risk model is and why that's valuable for the nation as a whole, but also for the organization that's trying to put these patients and providers together.
Yeah, absolutely. So before I would love to get to the risk model. One question before that is, I'm wondering if this is a complex topic, but I have always heard when I've listened to some of the content that you've put out in some of your strategy, leading with the economic reasons behind what the model is that you are in now, and the economic case for risk. And so when you look at the economic case for risk, what's the quickest version of that you can give before we get into the actual economics of the WellMed model and some of that strategy that I think we would encourage insurers to consider?
Yeah, I think it's interesting. I mean, people always try to solve the problem that's going on in our society in terms of the cost of healthcare being exorbitant. And I think we have a couple of slides that kind of talk to that. But in my view, one of the ways to best understand how to solve a situation like that is to understand how you got there. And, there are a lot of things that the United States has done over the years that have driven us down that path, and not the least of which is, instituting national health programs that have increased demand, but not put constraints on supply, or not put constraints on the amount of demand that would be utilized. So putting out the Medicare program in the 1960s really pushed forward an increase in demand. And then if you understand economics, it's an inelastic demand, because there's not a top line for the level of care that people are going to seek. They're going to continue to seek as much as they can for as long as they can, as long as the cost to them is minimal. And as we continue to go down that path, one or two things are going to have to happen. And my solution, and the solution that I kind of talk about a lot, is the solution that's based on putting providers and systems into a risk-based environment where they're incentivized to make sure that the care is adequate and appropriate, that eliminates unnecessary care, et cetera. We'll talk about that some.
Mm-hmm.
But the solution that the United States has tried to do is not necessarily gone down that path. It's really just been add more and more and more and more care and give more benefits without a cap on the amount of benefits that a person can receive. And as a result, it's driven this fee-for-service system that has driven the cost through the roof and has driven unnecessary utilization of care through the roof. Some studies would indicate that as much as 30% or more of the care that's being done in the United States, or $600–700 billion worth of care on an annualized basis, is unnecessary. And as you move toward risk-based systems where you're putting all the players together that have the same incentive, which is to provide the right care, the right outcomes, and the right quality and the right costs, then you start to eliminate that unnecessary care because everybody's incentivized to do that. As long as you have a churn as you earn fee-for-service system where everybody's incentivized to do the opposite and actually providing care is where you get your money, then you're going to continue to get unnecessary care, and you're going to have care and the unnecessary care bubble is going to continue to rise. So as a nation, as organizations, in order to make our products more appealing, in order to make our products as an insurance company, in order to make our products more cost efficient to the customers that we're trying to sell, then we've got to think about how do we manage those costs, and risk is the way to do it, in my view.
Yeah.
And in addition to that, so when you turn to the WellMed model and to the Optum care model, it's really risk that's managed by primary care physicians.
Mm-hmm.
So we're out there in the world bringing in primary care physicians that have the same mindset, that want to that are willing to take on risk and willing to manage those patients in a way that provides the best quality, the best care, and the best outcomes for those patients.
Yeah.
And we've been pretty successful at doing that.
So you've talked quite a bit about a paradigm shift in healthcare, and when you have talked about paradigm shift, this is what you mean, which is understanding how to manage risk and understanding how to incorporate risk into a provider network strategy.
That's exactly right. Yep, exactly right. And in the past, when we've tried to, we've realized, I think everybody has realized that the way to manage the system and to modify the behaviors of the patients is to get folks, particularly physicians, involved in providing the adequate and the right amount of care.
Mm-hmm.
And in the past, we've had insurance companies that have been, the focus of the insurance company is to put in care delivery or care management modules, put in incentives to provide to physicians to get them to provide the right level of care, et cetera. And it's been marginally successful at best. Those insurance companies have not been as successful as the companies that are out there doing it today, whereas the physicians themselves, the medical groups that are in the communities are able to go out there and incentivize themselves to do this in the right way. And it provides a lot more powerful means toward moving toward a 5-star plan or a low-cost plan or a high-quality plan. It's much more effective to do that from the medical group than it is to do that from the insurance company. And I think I have a slide, I think one of the last ones that I sent you, David, that kind of shows the paradigm shift of how things are moving. And you'll see, whereas insurance companies in the past have been huge parts or the majority revenue of their organizations, that is changing. And kind of much like, the energy companies are investing, the oil companies are investing in green energy because they see that as the future, and that's the type of thing that's going to eliminate them and make them irrelevant in the system. These big insurance companies out there, the big United Health Group, Humana, others, are out there moving toward care delivery organizations. There's a lot of them. Every one of the insurance companies, all the big players, are now participating and partnering with care delivery organizations to drive their improvements. And whereas in the past, if you look at this slide, those functions in the middle were all done by the organization on the left, right? They were all done by insurance companies. In the future, and in some cases in the present, these parts of the system are being done by the group on the left, on the right. So we're moving, so through, through necessary osmosis, those functions that have been done by the insurance company to marginal or sort of marginal outcomes are moving over to the group on the right that are doing that in a much better way, a much more effective way, because it's being done at the point of care. And so this is the shift, I think, that's taking place in the system. And as this shift takes place, so does the sort of the power hub of what's going on. The leverage of that sits in the system no longer sits with the folks that will no longer sit with the groups on the left. It'll move toward the groups on the right. And that'll continue to evolve over time to where physician groups, even CMS, when they're talking about doing things such as direct contracting with physicians in the community, they're realizing that the influencers of the future are not going to be the groups on the left, and probably not even the other ancillary services, the hospital systems, the specialists out there. They're going to be these groups on the right. And it's, in the past, we tried to get there, right? Through managed care in the 80s, we tried to get to the place where we're going to try to have PCPs that directed care and helped to manage the care, and it never got there because incentives were never aligned correctly. But today, we're in a place where we are starting to align the incentives correctly, and it's actually working. There's another slide, I think, Dave, where we talk about those trusted agents. I forget which one it is, but when you look at, I think it's, yeah, it's that one with the green bars on it. Go up, yeah, right there. So if you look at the folks that people trust, I mean, the reason why managed care didn't work where insurance companies were kind of driving the outcomes is because nobody really trusts us as insurance folks, right? I'm an insurance guy. I was in the military for 20 years as a hospital administrator, but then post the military, for several years, I worked with insurance. And we're not the ones that folks out there trust, right? So the patients aren't looking to me as Humana or United or Aetna or Cigna or Centene. They're not looking to us to be the ones that are concerned about them. They're looking to those guys at the top. So they look at the nurses and the doctors and the pharmacists as the ones that they can trust to provide their care. And so when the nurses, the doctors, and the pharmacists are out there suggesting that these things are the right path, then they're going to follow suit, and they're going to take note and make those choices in accordance with the guidance from their trusted advisors. And so as we move from a place where we're not trusted to a place where we are trusted, then we start to see the behaviors of the patients really start to change and modify. We don't even find, Dave, in our systems, it's really helpful to have a controlled system to where you can direct patients to the specialists and hospital systems that you want. But we find as folks start to trust, the patients start to trust our physicians, that's not even necessary to have a control in place. It's helpful, and certainly it's better, financially, and we get to slightly better outcomes, but they trust our physicians so well that even if we don't have contractual controls to make sure that they're moving in those directions, if our physicians and nurses suggest that they go to a certain place, they're going to go to that place. Mm-hmm. And so the site of care issues become less important as we move toward if you move the patients toward those groups at the top of the list here. Yeah. And they start to trust them.
Absolutely. One of the questions that I've heard asked of you before is to say when you start to look at that paradigm shift and look at PCPs driving a lot of the growth from a provider strategy perspective. How does that type of model or shift impact or have any relation to provider burnout, right? Which we know a lot of folks on the phone that are dealing in provider strategy as we're trying to build networks and figuring out how to position that. What does that sort of shift lead to in terms of burnout?
Yeah, it's a great question. We find that when you give physicians the ability to do and perform care and take care of patients in the way that they wanted to coming out of medical school, that the burnout is much less. Mm-hmm. And we're not asking physicians to churn to gain as you move into a capitated model. So as you move away, I think your question is, as you move away from a fee-for-service model to a capitated model, to where you have accountability for the care of those patients completely, then we find that the physicians know that they are incentivized to provide the right care, and they engage fully with those discussions. They're not concerned about, getting through a 15-minute appointment they'll take as long as they need to on that appointment, and it doesn't stress them in any way. They want to find out what exactly is going on with that patient, and then make sure that they're putting in place the processes and procedures to ensure that that care is being taken care of appropriately.
Mm-hmm.
They feel a lot better being a part of the system.
Yeah. What about and another question that I've heard of asked of you recently is just post-hospitalization support too. And so when you go back and you build a model and build a provider strategy with PCPs in mind, how does that relate to post-hospitalization care and sort of that experience for the patient?
Yeah, I mean, they're a part of our family. So the way they see it, so our physician panels, instead of having, our physicians on the Medicare side primarily, instead of having panels of 1,500 patients, they'll have panels of 350, 400, 450 patients and manage those effectively.
Mm-hmm.
And so as a result, they know what's going on with each one of those patients very intimately. And their staff, they're very robust staff that's designed to support those patients and to support them, also knows what's going on with those patients. So as anybody enters and exits a hospital environment, we're right there to support them in terms of, post-acute care management, et cetera. So it really facilitates the ability to do that. And knowing that, and further knowing that, we're accountable. So as a physician, we know that as a physician, the organization knows that they're accountable for the care that they're being provided and the cost of the care that they're being provided. There's a tremendous incentive to make sure that, we're really taking care of those patients and ensuring that they're not being put back in the hospital unnecessarily.
Sure. What question for you then, as we shift a little bit topically to the world's response to COVID-19, just at a very high level, walk me through the economics of how type of approach to a provider strategy and that type of a response, right, from an insurer.
Yeah, that's a really interesting question. I mean, I got a lot of peers, colleagues in the community who have really struggled and continue to struggle through the COVID-19 scenario because their revenue stream and their expenses are being covered by seeing patients on a regular basis through the fee-for-service model. And as a result, when patients aren't coming in to be seen, then their business starts to dry up as a business. And it becomes difficult for them to pay their bills. It becomes difficult for them to take care of the patients effectively, et cetera. A lot of them have put in place, necessarily so and smartly so, video teleconferencing, things like that, video appointments, to try to help facilitate the care and quality of the patient and the quality for their patients, but also to facilitate the continued running of their business. And as a capitated entity where most of our business is done through a capitated system, we didn't see it the same way. We definitely, our capitated payments are the same regardless of how many times we see the patients. Our issue has been not ensuring that we keep our doors open by seeing the patients. Our concern has been, let's make sure that we're staying in front of the patients, talking to the patients, identifying their issues, helping them can deal with their issues as they're stuck in their homes. Most of our patients at WellMed, most of them are seniors, and they're the ones that have been most affected by COVID, and they're likely more prone to be, sheltered in place, et cetera, necessarily so. And so we've done things like taking physicians to them. We go to their place, to their homes to see them, to make sure that they're getting the care that they need, to make sure that we're identifying the conditions that they have that we can help them with. And we're doing all kinds of video teleconferencing, et cetera, to make sure that we're providing the care that we need. But we're not doing it for the reasons that a lot of fee-for-service businesses are doing it. And we're doing it to take care of our patients. We're not doing it to keep the lights on.
Yeah.
So it really becomes a different kind of crisis for us. We really want to make sure that we're out there seeing our patients and identifying the things that they need help with. But we're not interested in doing it to keep the business running.
Sure. In talking to a lot of folks and honestly specific folks on the phone listening to this today, you touched on a really interesting topic, which is social isolation, especially those, if you look at those 65 and older. As it relates to government programs, I know that a lot of health plans, this is such a hot topic to make sure that we can, as best we can as healthcare providers, understand and help mitigate the effects of social isolation for all the healthcare outcomes that follow. It sounds like this sort of this model of physician-led care really has been a natural way to sort of battle the effects of social isolation. And I'm wondering what the early results have been as y'all have, just like the rest of us, been navigating some of coronavirus as it relates to isolation. Is that something y'all measure? Is that something? Certainly, it's a benefit that's provided by some of the operations you just described. And I'm curious as how explicitly is that talked about with this model?
Yeah, we do talk about that quite a bit. We're concerned about the mental health of our patients that are stuck, in their homes without the ability to see their family members, et cetera. We don't have we don't have a lot of measurements around that, but we do put in place procedures and activities to try to help them with that, through our outreach programs, et cetera. So I don't have any data that I can give you on that, but I know that it's a topic of concern, and it's something that we're very focused on.
Yeah, helpful. In our last couple of minutes here, I wanted to give you the opportunity. We've got quite a few folks on the phone that are driving provider network strategy, figuring out how to pivot, exploring with different models, both from an economic perspective and what's right for their patient populations, depending on where they're at geographically. And wanted to just give you a couple of minutes to say what advice or what strategies would you share with them in our last 2 or 3 minutes here as something to consider over the next 6, 9, 12 months?
Yeah, I would say, continue to, when I talk to health plans, I think that most folks that are on here today are from health plans. I would say continue to move your organization toward sort of the value-based environments that we talked about, whether it's capitated or providing strong incentives to physicians to do care on your behalf, or delegating different conditions to them. So if you look back at that slide that we had up earlier, think about how you can, as an organization, move some of those activities from the organization that you're in to the physicians, because I believe, and I think the evidence shows that they're more effective being done at the point of care than they are being done at the back office of the insurance company. And I know that that's a challenging thing to do for insurance companies, because you look at it as if you're moving jobs away from where you are to another place. But altruistically and even financially and effectively, you need to figure out a way to make that happen in order to be providing the best care for your patients and at the lowest cost, so you can pass that low cost on to both your patients and to your potentially commercial customers, et cetera.
Mm-hmm. Absolutely.
We're all about value-based. We're all about moving toward a capitated, risk-based environment. And I think that, insurance companies that are going to be successful in the future are going to be moving in that direction.
Yeah. Makes sense. I know we are right at the turn of the half hour, so I will close it off there. For the folks on the phone, I would love to give you the opportunity. We did have a couple questions come in, but I just also want to be respectful of what we committed to, which was a 30-minute session. If you do have questions, would love if you just feel free to submit them. We will be emailing you, everybody who came today, we'll email you with a link to the recording and any materials that we used from the provider trust side today, if it's of interest. And when you get that, just feel free to respond with questions, and either somebody from our side at Provider Trust, or if appropriate, can pass them on to Eric, and we'll try to get some questions answered about some of the things that we're doing. So appreciate everybody's time today. And Eric, a special thank you to you. This has been amazing. Appreciate your expertise and your willingness to jump on the phone and help a few friends of ours in our networks. So thank you.
Yeah, I'm happy to do it. Hopefully it was helpful.
Yeah.
Thanks, Dave.
Thank you for the time, and thank you everybody else on the phone. Have a great rest of your Thursday.